So we are live in 3, 2, 1. Please start. We are live.
Good evening, everyone. I'm Dr. Vaishali Gupte, Director Medical at CIPLA, and it gives me great pleasure to welcome you to this webcast on topic OSA when CPAP fails. ORIENT provides platform for one-to-one interaction with experts in the field of otolaryngology and brings latest updates in this field. Objective of today's ORIENT webcast is to discuss on the management of OSA, and we are extremely honored to have eminent faculty members for this discussion today. Our esteemed moderator is Dr. Arjun Dasgupta, sir. He is Senior Consultant ENT and Endoscopic Skull-Base Surgeon at C.K. Birla CMRI Hospital, Kolkata. Dr. Arjun Dasgupta, sir, has over 25 years of experience in ENT practice. He has worked in tertiary referral hospital in UK for 4 years and has more than 12 years of experience in the UK. His expertise includes rhinology and anterior skull-base surgery. I really thank him for accepting our invitation. Our esteemed speaker is Professor Bhik Kotecha, sir. Professor Bhik Kotecha, sir, is a consultant ENT surgeon, honorary clinical professor at Barts and the London School of Medicine and Dentistry at Queen Mary University of London. He worked as a consultant for more than 25 years at the Royal National Throat, Nose and Ear Hospital, London, at Barking, Havering and Redbridge University Hospitals NHS Trust. He has developed a special interest in the management of snoring and obstructive sleep apnea. Professor Kotecha, sir, has over 100 presentations and publications, with the majority being on sleep-related breathing disorders. His publications include 2 textbooks, 9 chapters, and numerous peer-reviewed articles. I really thank him for accepting our invitation and being a part of this ORIENT. Now, I hand over session to Dr. Arjun Gupta, sir, to take it ahead from here. Thank you so much.
Hi, welcome everybody. It's a Sunday and it's 8 p.m. So we are going to have a very, very interesting session on OSA. And we are going to really concentrate on OSA when the CPAP fails. We all know that the CPAP is the gold standard treatment of OSA. We have all read that. But what happens when, with the compliance of the CPAP, when people fail to take the CPAP? What do we do then? It's a very important part of the topic. And we are very honored to have Professor Bhik Kotecha with us in here. And let me tell you that it's such an honor for me to share the space, virtual space, meeting space with Professor Bhik Kotecha, because he's one of my teachers. He's the one who has taught me ENT surgery and especially the sleep medicine part of it. And it's a Teachers' Day in India. So happy Teachers' Day. Please allow me to express my respect to Professor Bhik Kotecha. Professor Kotecha, please go ahead and say what you have to do. Only one thing, if you have any question, please type your question in the chat box. We will take the questions at the end, not in between the meeting. Thank you very much. Let's start.
Thank you very much, Arjun, for that very kind introduction, and thank you very much, Dr. Gupte. I would like to share my experience over the last 3 decades. As an ENT surgeon, I developed an interest in evaluating and treating upper airway obstruction, and I'm hoping over the next 40-45 minutes, I'll enlighten you on some of the things that I've worked with, particularly and specifically focusing on what to do when CPAP fails. So greetings from London. It's a very nice sunny afternoon today. India and England are playing the test match, and I think India have scored about 430 runs for 8 wickets. So it's a good day here. So greetings from London, UK. So if anybody wants to switch off now, they can read this paper that we wrote in 2017, and it covers almost everything that I'm going to talk about this afternoon. Sleep disordered breathing consists of a variety of syndromes and symptoms and disorders like snoring and obstructive sleep apnea. But interestingly, it's a relatively new discipline, and it attracts people from a variety of specialties. So the biggest attraction would be for the respiratory physicians, but more and more commonly now the ENT surgeons are coming into it, maxillofacial surgeons, dental surgeons, psychiatrists, and neurologists. So we as ENT surgeons look at the upper airway, and in patients who have snoring or obstructive sleep apnea, they have a very turbulent airflow anywhere from the nose to the larynx. This therefore causes an upper airway resistance, and any anatomical obstruction or redundant pharyngeal mucosa is what we call the turbulent airflow. So as a result, if the patient is mouth breathing, you will have a lot of problems with the upper airway, in that the tongue will retract and occlude the laryngeal inlet, and the pharyngeal mucosa will vibrate more aggressively. I don't really need to go into the nitty-gritty of the diagnosis, the clinical history, etc., because I'm sure most of you are familiar with this. But needless to say that the salient features in the clinical history are important. We witnessed apneic episodes, the excessive daytime sleepiness, unrefreshing sleep, or morning headaches. Now, the important bit is the clinical examination. From an ENT perspective, we are very apt at using the endoscope, and we like using the endoscope. But what I must emphasize here is the importance of evaluation is key to the treatment. So you would like to do the endoscopy whilst the patient is awake and is fully in control of their muscle tone. But if possible, and when necessary, to do the endoscopic examination during drug-induced sleep endoscopy. And I will talk a little bit more about this during the talk. And then you have a choice of making the diagnosis with either an ambulatory home sleep study or a full hospital-based polysomnography. But again, this is something that would be very familiar with most of you. It has been very well documented that both snoring and obstructive sleep apnea exhibit a multisegmental phenomenon. And a variety of techniques have been used to do this, including acoustic reflection, fluoroscopy, cephalometry, CT scanning, dynamic MRI studies, sleep nasendoscopy or drug-induced sleep endoscopy, and the pressure transducers using apneographers also demonstrated this. So as you can see on the right-hand side of the screen, your pharyngeal lumen, the nasopharynx, the oropharynx, and hypopharynx would be affected in most individuals, and majority of these people have what we call a multi-level obstruction. So why would you think that an ENT surgeon need to evaluate these patients? Well, you need to evaluate the patient because you can then offer a site-specific treatment, which would be individually tailored, and this would include both surgical and non-surgical treatments. And I will talk about the non-surgical treatment, specifically the mandibular advancement device and how you can use evaluation techniques to predict successes. You can avoid unnecessary surgery if you do this. And this is an important point, which again, I'll labor on later on. And you can offer your patient a choice of treatment. So sleep nasendoscopy or drug-induced sleep endoscopy was pioneered at the institute where I worked for about 30 years. On your left, you can see Charles Croft and Mike Pringle. They're the one who described it initially in 1991. And I started working with them at the end of the 1991, so worked with them for quite some time. We at the Royal National Throat, Nose and Ear Hospital have a wide experience and a great experience on sleep endoscopy. Essentially, we have patients who do not use CPAP or who have failed CPAP will undergo this endoscopic evaluation during drug-induced sleep. The choice of drug we have is a combination of midazolam and propofol, although there are other units that will use different drugs, but this is the most commonest drug used, and your anesthetist is the most important person in this thing. So our first publication on this was in 2007, when we looked at 2,485 patients that we had looked at, and we had modified the technique of Croft and Pringle by advancing the mandible a little bit during the procedure to mimic what a mandibular advancement splint would do. And I will show you some video recordings of this to enlighten you more on that. This is our breakdown of nearly 2,500 patients. And for those of you not familiar with the grading system, grade 1 is when you just have palatal flutter. Grade 5 is when you just have tongue-based and or epiglottis obstruction. So 2, 3, and 4 are multi-level. And if you add this up, this would give you a total of about 75%. So that implies that 75% of the patients with obstructive sleep apnea will have problem at more than one anatomical site. Again, when you look at the correlation between the sleep nasendoscopy grading and the AHI, the apnea-hypopnea index, then you will find that between the higher index from 15 onwards will be more commonly seen in grade 3, 4, and 5. So this is an example. And again, the sleep endoscopy is a good way of seeing whether the patient will have any issues with CPAP or not. This first video that I'm going to demonstrate is a palatal flutter only. So if a patient has to use CPAP, it shouldn't be a problem. So here we go. So this is just palatal snoring. And you can see the vibrations of the soft palate. It's in the AP dimension. What we do during this technique is to just lift the jaw by about 3 or 4 millimeters to see what a mandibular advancement device would do for this patient. And you will see in a minute, it will open up the nasopharynx and oropharynx a little bit. The vibrations will not settle down completely, but it does actually change the pitch of the snoring, and it's less aggressive. And a patient like so, if they had to use CPAP, would be absolutely fine with that. Now, this is somewhat different to the next video that I'm going to show. Now, look at this. This is a video, a sleep endoscopy video of a patient who has multi-level collapse. So first of all, we're in the oropharynx and upper part of the nasopharynx, lower part of the nasopharynx. You will see some palatal vibration. You will also see the tonsils will collapse and come into the midline. And you will see the epiglottis. You will see the epiglottis there being sucked in. It is being sucked in into the laryngeal lumen. So if a patient like this were to try and use a CPAP, they would probably struggle. And that is why when you have patients who fail CPAP, it's important to refer these patients onwards for an assessment like this. Now, this is with the jaw lift. When you lift the jaw, the laryngeal inlet opens up. But as soon as you relax the jaw, the same thing will be seen again with the epiglottis dropping down on the laryngeal lumen. Similarly, this is the grade 3 sleep endoscopy. You will see lateral vibrations, nasopharyngeal, oropharyngeal collapse. And if you wait for it, right at the end, you will see the tongue base and the epiglottis almost completely occluding the larynx. So once again, if you try treating this patient with CPAP, they would fail. So in general, the treatment options for obstructive sleep apnea are as follows. You can have lifestyle changes and ask your patient to lose some weight, reduce alcohol and smoking, or you can use appliances like simple nasal strips, oral devices, or CPAP. Medication like antihistamines and intranasal steroid sprays for allergic rhinitis might also be helpful. In terms of surgery, what I'm going to cover is talk about soft tissue surgery only, because the skeletal framework surgery, although it's very important and useful, that's usually done by maxillofacial surgeons. So in terms of appliances, the two commonest ones, and the commonest one would be CPAP, continuous positive airway pressure, for moderately severe or severe sleep apnea, where the apnea-hypopnea index is more than 15 per hour, and the patient is complaining of daytime sleepiness, morning headaches, snoring, and tiredness, and CPAP would work very well, provided they're able to use it. Mandibular advancement splint or device was also useful in patients with mild sleep apnea, but I've got a patient with severe sleep apnea on my presentation today who did extremely well with this. And I'm going to show you that in terms of sleep studies and sleep endoscopies. So whilst these devices are effective and in comparison to surgery, they're relatively non-invasive, the compliance is not always great. The patient acceptability is not uniform. And they have to use these devices every night. You do have a group of patients who want a one-stop fix and therefore would prefer surgery. So let's talk about CPAP first. According to the NICE guidelines in the UK in 2008 and more recently in 2021, CPAP is the gold standard treatment for moderately severe or severe obstructive sleep apnea. However, it is somewhat cumbersome and the compliance is poor, as we already mentioned. Needless to say that there are problems like CPAP rhinitis and aerophagia and claustrophobia that patients will complain of and can't use CPAP adequately. This was an interesting paper by an ENT surgeon in Canada, Brian Rottenberg, a friend and colleague of mine, who in 2016 published data on the trends in CPAP adherence. He looked at studies that covered a 20-year time frame, and he found that there were 82 papers that met this criteria, and the rate of adherence was relatively low. So the failure rate was about 35%. So on average, between 30 and 40% of the CPAP patients will fail treatment. This is a large group of patients that really require help, and the best help you can give them is to refer them onwards to your friendly ENT surgeons. This is particularly the case in younger patients. They just don't want to use this device night in, night out for the rest of their life. And the reason why they can't use it, perhaps, is due to an obstructive upper airway, which can be rectified and corrected. So we published this in the Journal of Thoracic Disease in 2016 about when CPAP fails. And this is something that the NICE guidelines in 2021 have also suggested, that if the patients fail CPAP, they should be referred for upper airway evaluation. Because if you can correct the upper airway obstruction, the patient may no longer need CPAP, or even if they do need the CPAP, it may be at a lower pressure and therefore the CPAP compliance would be better. So before talking about evaluation for surgery, let's just talk about oral appliances. So you can have tongue retainers, you can have mandibular advancement devices, and this may be simple things like boil and bite device, or it may be the Rolls-Royce model where it's made to measure. So this is a patient with the mandibular advancement device in situ. You can see that the patient's got an acrylic splint like this. This is the Rolls-Royce model that we use here. It's called the HERBST Mandibular Advancement Splint, which is a two-piece device. And it's got a titanium plate here, which makes the lower jaw protrude about 4 or 5 millimeters anterior to the upper jaw. So obviously, these patients, you have to make sure that they do not have TMJ dysfunction or do not have epilepsy, and they've got enough healthy dentition to support an oral appliance. So this is the patient that I want to present to you. This is a patient who's got a lateral view of the neck with and without the splint. So this is without the splint, and you can see the retropalatal retroglossal distance is compromised. And this is with the splint, and you can see the retropalatal and retroglossal distance is immensely improved. Similarly, when we do the sleep study before and after, or before and with the mandibular advancement device, preoperatively, you can see the AHI was 59.9. This is severe sleep apnea. With the mandibular advancement splint in situ, it dropped down to 5.1. And look at the charts. If you look at the top line here, you can see frequent oxygen desaturations. Do you see that? And on the right-hand side, this is very minimal. Look at the snoring here. You can see the snoring signal quite loud here and only a little bit of snoring here. Look at the bradykardiotychias. This is the bradykardiotychias, and the heart rate fluctuation is immense with severe sleep apnea, whereas with the splint in position, this is less. But more importantly, the sleep architecture. Look at this bottom chart. The sleep architecture. Here you've got so many micro-arousals and very minimal REM sleep. Whereas on this chart here, the sleep cycle is a bit more normal, and you've got 3 phases or 4 phases of rapid eye movement sleep. So really an immense difference and improvement in the sleep studies before and after. So the same patient underwent drug-induced sleep endoscopy with and without. So this is the drug-induced sleep endoscopy without the mandibular advancement device. So let's see if this plays for us. You can see the plane of the nose, the maxilla, and the mandible. And observe these 3 lines, because when we have the splint in position, it will change. The whiteout effect is because the patient is having an apneic attack.
Patient's having an apneic attack now. Saturation's dropped to 91.
You can see complete collapse of the oral pharynx.
It's getting louder.
So this same patient, immediately within minutes of that video, had this. The appliance is in position now.
And immediately we can see the difference.
You can see it opens up. You can see the epiglottis quite clearly.
The epiglottis retracting a little bit.
And look at this plane. This is where the mandible was before. And look at it here now.
The snoring has diminished. The oxygen saturations are now, in fact, 97%. You can see the oral pharynx is fairly patent, as is the nasopharynx. The difference the dental plate has made of this patient is remarkable. We now have objective evidence from the sleep study that this apnea index diminished from 50.9 to 5.1. And also from the sleepiness endoscopy with and without the plate, we can see that it has improved his airway as well as his snoring. The patient certainly is very happy with this form of treatment.
So obviously, the mandibular advancement devices are not without side effects. And this is one of the papers we wrote in 2005, demonstrating that if you use it for a long period of time, you can end up with marked bite changes. But you tell your patient to take a day or 2 days off a week so that they're not using it 7 nights a week. So now to the crux of the matter. As an ENT surgeon, I'd like to talk more about surgery. And the upper airway surgery can be divided into 2 different categories. First and foremost, and the most commonly performed surgery is intrapharyngeal surgery. This is surgery performed within the pharyngeal lumen to improve the pharyngeal lumen. Or you can have extrapharyngeal surgery, which is things like hypoglossal nerve stimulation, where the surgery is being done outside the pharyngeal lumen, but in order to improve the dimensions of the lumen. And finally, something that I'm not going to talk about much is the skeletal framework surgery, which is really quite effective. I've got one slide on it right at the end of my talk, and I'll talk a little bit about it then. Tracheotomy, in the last 25 years, I've only done 2 tracheotomy for sleep apnea, and it's not the done thing now, but before CPAP came into being, tracheotomy was quite commonly done for sleep apnea patients. Bariatric surgery, again, is out of the remit for this talk, but it is something that is considered for very obese sleep apnea patients who might have the metabolic syndrome or the syndrome X. This is something that we've written in 2018 in Breathe, and we did surgical intervention to treat OSA, individually tailoring the needs of the patients. I'd like to share my surgical philosophy with you. And the bottom line is, do no harm to your patient. It is important to carefully evaluate and select your patient. It is important to know who not to operate on. It is important to know what operation for which patient. And you start off with minimally invasive surgery and then move on to more radical surgery if necessary. And bear in mind that surgery might not be successful on its own, so you might have to combine surgical and non-surgical treatment modalities. So, for example, surgery with a mandibular advancement device. So, why upper airway surgery? Well, you may be able to completely resolve the upper airway obstruction and therefore improve the upper airway dimensions. And as I mentioned earlier on, you can reduce the CPAP pressure and improve the CPAP compliance. So surgery for sleep apnea and snoring and sleep disordered breathing is not new. Even in the Hippocratic era, 2,500 years ago, they were using loops to remove nasal polyps, which they thought was causing snoring. Tracheotomy is really the last resort, and there are papers by Guilleminault, which shows 100% effectiveness. But obviously, that's not a surprise, and that is what one would expect because you're bypassing the upper airway obstruction. But the important thing here is patient acceptability. Patients will not accept a tracheostomy for the rest of their life when they've got other measures such as CPAP, oral appliances, and/or surgery. So correction of the upper airway, as I've mentioned, it could be simple or complex, and soft tissue versus skeletal framework. I'm going to go through some of these now. Now, my apologies to the ENT surgeons. I don't need to show you what a deviated septum looks like, but I gather that we have some respiratory physicians amongst us, and they may not be familiar with the endoscopic view of the nose. So this is a patient where the right nasal cavity has been vasoconstricted, and you can see a gross deviation of the nasal septum impinging onto the lateral wall. Now, this is after decongestion, so you can imagine with the scenario before the decongestion, patient would not be able to tolerate CPAP. Similarly, if you've got grade 3 nasal polyps, again, in endoscopic view, patient cannot use CPAP. And this is what we do with functional endoscopic sinus surgery. You can see the polyps are huge. They're about 3 centimeters. And if a patient's got bilateral nasal polyps, they will not be able to use nasal CPAP. But this is the place where the ENT surgeons will be able to help your patient. Having spoken about nasal sinus surgery, the commonest operations we would do is septoplasty, turbinate introduction, and endoscopic sinus surgery. But it is for certain that nasal surgery alone will not cure sleep apnea. There are numerous studies that have been done. For simple snorers, you have a short-term improvement, but the AHI does not improve just with nasal surgery. And this is something that is accepted worldwide. So the effect of nasal surgery on CPAP device is something different. Camacho looked at the systematic review and meta-analysis where they looked at 18 different studies with 279 patients, and nasal surgery alone was sufficient to reduce the CPAP pressure requirements and therefore improve the CPAP compliance. So if you go beyond the nose into the postnasal space, this is an adult with a huge adenoidal tissue completely occluding the choana. So this was actually a lymphoma. So you need to make sure that where your patients have failed CPAP, they're referred onwards to the ENT surgeons who can pick up the odd rare pathology like that. Now, without doubt, the commonest surgery that is performed for snoring and sleep apnea is palatal surgery, soft palate surgery. And this started in the 1920s when Trotter initially just did uvulectomy. It was then Fujita in the 1970s that popularized uvular palatal pharyngoplasty as we know it, or the UPPP. But so much has happened, and the palatal surgery has evolved. There's been radiofrequency, lasers, pillar implants, and various modifications of the soft palate. So for the non-surgeons amongst us, this is what a radical UPPP would do. It would take about 1 centimeter of the whole of the soft palate. And this is quite a painful operation. There's increased morbidity and mortality with this. And I personally have not performed a radical UPPP for the last 25 years because I use the modifications. And I will talk about some of the methods that are available for us and some of my preferred techniques as well. So you've got to be careful that you do not create any complications that are going to be troublesome, in particular nasopharyngeal stenosis or velopharyngeal incompetence, whereby when they drink, the fluid comes out of your nose. It has also been thought that if you radically operate on the palate, they can have problems tolerating CPAP later on. So the evolution of palatal surgery has been done in order to make the surgery less radical, but more functional. So Kenny Pang and Tucker Woodson described the expansion sphincter palatoplasty, which is very useful for lateral wall collapse. Michael Friedman in Chicago introduced a Z-plasty. Lee et al. Introduced a relocation pharyngoplasty. The Italians, my friend and colleague Claudia Vicini, has described the Barbed reposition pharyngoplasty. And Tucker Woodson has dealt with the transpalatal advancement flap. So there's a lot of different things that are available for a lot of different disorders. So this is an interesting Italian technique, the Barbed reposition pharyngoplasty. I mentioned this because I came across an article from an Indian gentleman by the name of Sandeep Gachuri, who I believe works in Bangalore, and he worked in conjunction with Claudia Vicini and looked at the Barbed reposition procedure in the Indian population, and they published this paper in the Indian Journal of Otolaryngology, Head and Neck Surgery in 2019. Vicini has done randomized control studies, and it is really demonstrated that in the selected patients, the Barbed reposition pharyngoplasty works really well. Michel Kahali in 2003 initially described the lateral pharyngoplasty, and he's actually modified his technique at least 5 or 6 different times with slight modification. And it's quite a lovely technique, but you need to know exactly what you're doing. So with this technique, and also with the soft palate collagen and elastic fibers, it has been demonstrated that it's a type 1 collagen fibers that are more prevalent in obstructive sleep apnea, and they are responsible for the increased collapsibility. And by doing the techniques that Kahali has suggested, he claims that it changes the structure of the pharyngeal upper airway dilator muscles and is more conducive to keeping the airway patent. Laser palatoplasty, we've got 24 different techniques. So people use different techniques, they modify their own techniques. I have my own technique, and I'll show you a brief video on that. And that is to show you what changes can be made to the anatomy of the soft palate. Obviously, there are complications. You can get bleeding up to 2 or 3% of the patients. The voice changes in about 7%. This is change in the resonance, but it resolves by week 6. And similarly, the nasal regurgitation resolves by 2nd week. The most annoying postoperative problem is globus, or sensation of a foreign body in your throat. So if you've got tonsils like this, kissing tonsils, grade 4 tonsils, your patient is not going to tolerate CPAP. You've got a patient with unilateral enlargement of the tonsil. You can see that the patient has got a unilateral enlargement here, and this turned out to be a lymphoma. So again, if a patient is not tolerating CPAP, have a look inside the mouth, see if there's any problems. This is one of the patients that I had where I saw the oropharynx was compromised, and the patient required, after the sleep endoscopy was done, required tonsillectomy and the laser-assisted palatoplasty. So this is my technique, the Kotecha technique for laser-assisted palatoplasty. So I like using a CO2 laser, which is microscope mounted. I do this procedure under a general anesthetic because the tonsillectomy would have been done. You can see that there are swabs in the postnasal space and protecting the pharyngeal wall against inadvertent trauma from the laser. And I've taken off this redundant posterior pillar. The same things, I made marks here about 25% of the whole length of the soft palate. So in this patient was about 1 centimeter. And the trench that is made is through and through to the palatal muscles. As you can see, there's hardly any bleeding. And again, we pull the posterior pillar medially and remove a little crescent like this. And with the uvula, I don't take the whole uvula out. I just resect about 50% of the uvula and cut it obliquely. The reason for cutting it obliquely and leaving the posterior edge of the uvula longer than the anterior edge is that it will heal better and you will get a nice short neo-uvular stump. I do not stitch it, I just leave it to heal by secondary intention, and this is what it looks like after surgery. So as you can see that the oropharyngeal dimensions have improved, and again, if this patient still needs CPAP, the CPAP pressure requirement will be less. So we've done a number of papers on my technique. The initial description was of the technique. We've done short-term results, long-term results of 5 years, and we've used this technique for CPAP failures. So this was the one that we used for CPAP failures, a select 20 patients that we used, and we found in this group of patients following the surgery, the mean AHI reduced from 47.9 to 12.9 per hour. And of these patients, only 10 were using CPAP. The other 10 didn't want to use CPAP. And of the 10 that were using CPAP, 8 no longer needed CPAP. And the 2 that resumed on CPAP were at lower pressure and they tolerated better. So this is just a chart to show how the apnea-hypopnea index improved in these 20 subjects. Similarly, the Epworth sleepiness score also improved. There have now been randomized control studies for palatal surgery from the Karolinska Institute, and this is very supportive of palatal surgery for OSA patients. Similarly, the multi-level surgery, there are advocates for this, and people like Kenny Pang in Singapore, Stuart Mackay in Australia, and other group in UK have said that multi-level surgery is very useful. More recently, Stuart Mackay's group did a randomized control study on sleep apnea multi-level surgery, and this was published in the JAMA, demonstrating that it is a very useful procedure indeed. Now I'd like to spend some time talking about robotic surgery and using the Da Vinci system. This is very useful, and it is minimally invasive in many respects, and it has the advantage of getting rid of your tremor, and the depth of perception and all those things get better. Robotic surgery for sleep apnea was first started by Claudio Vicini, and in 2012 he published his paper with 108, but I think he has now got about over 1,000 patients where he's treated with sleep apnea using the robotic technique. We in the UK, we've done about 95 patients, but our first 25 were presented in 2015, and we found that this to be quite a useful technique. So selection criteria is important. You can see on this MRI that the low triple L, so low localized lymphoid tissue, are the ones where we find that these are going to be quite appropriate for robotic surgery. So this is just a sleep nasendoscopy video demonstrating the base of the tongue collapse, and you can't see the larynx at all. Similarly, if you look at this patient here, this is the epiglottic trapdoor phenomenon. Again, patients like this will not be able to use CPAP because the CPAP will push the epiglottis into the larynx and will not work. So the outcome measure for a robotic surgery, the primary outcome measure was to get the AHI less than 50% of what it was, and the secondary outcome measures were patient-related outcome measures looking at quality of life, the voice, the swallowing problems, and pain. So I'm just going to go through a few 20-second video clips about this patient's pre-op flexible nasendoscopy, awake. You will see that in this patient, the problem is mainly at the level of the hypopharynx. The tongue base in the epiglottis is almost impinging on the lateral wall there. This is a robotic approach with a thulium laser here. You can see I'm marking out where I'm going to vaporize the tongue base, and we use a thulium laser. There's hardly any bleeding with this, and you can see that we've made a mark which is about 2 centimeter by 2 centimeter by 2 centimeter deep. And here you can see there's further charring and vaporization of the tongue base, lymphoid tissue, and the muscles as well. And the crater will be 2 by 2 by 2. Here you will see I'm resecting the epiglottis using the robotic technique. And people have questioned that when you resect an epiglottis like this, do you not get aspiration or penetration? And the answer is, in the 95 patients that we've done, we haven't experienced this, fortunately. Initially, they have some swallowing difficulties for the first 2-3 weeks, but thereafter they settle down and get accustomed to it. As you know, that the protective component for the upper airway is from the true vocal cords, the false vocal cords, and the epiglottis. And in this case, the epiglottis is only partially resected. And I'll show you what it looks like after a month. There you are. That's the epiglottis wedge that I've taken out. So this is now the view. You can see that the wedge has, there's some charring of the epiglottis, but there's still some epiglottis left behind. And you can see the posterior third of the cords quite clearly. This is the postoperative flexible nasendoscopy, and you will see how the epiglottis appears. There's an epiglottic remnant. You can see that here. You can see the tongue base is less bulky, and there's more space here now. So the cure rate in our series was 86%, with the pre and post-op apnea-hypopnea index being much better. Similarly, the Epworth score was better as well, and quality of life questionnaire after 3 months was great. The swallowing function in the first 3-4 weeks was slightly impaired, but then got better. MRI images have shown the objective improvement in the upper airway. Now, finally, in the last 5 minutes or so, I just want to talk about electrical stimulation for sleep disordered breathing. This can be divided into 2 big categories, the non-invasive and the invasive. The non-invasive could be divided of the stimulation during sleep, and the very new novel technique, which I've had personal experience and done some research on, is the Excite OSA, where the stimulation is done during wakefulness. And of course, then the invasive hypoglossal nerve stimulation, which I'll talk about in a minute. So the transcutaneous electrical stimulation, or TESLA as it's called, was first described in 1989, but the results were not really very good even in the 1990s when Guillemino tried to replicate the results. He couldn't get that. It wasn't until 2011 when Professor Jörg Steyer, who's from Guy's and Thomas's and King's in the UK, did the feasibility study. And according to him, and I truly believe in this, the key to success is that you only sufficiently stimulate the tongue without causing an arousal, because this is done during sleep. This is transcutaneous patches in the submandibular region here, which will stimulate the tongue. So there have been a variety of papers on this, and it's a new emerging technology which works, and people can do the domiciliary home test that program, and there's a lot of material on this in the literature, which is very supportive. So the paper that I want to talk about now is the Excite OSA. This is something that I work with personally, and this is a device that causes neuromuscular electrical stimulation during wakefulness. You only use this device whilst you're awake, and I'll tell you more about it. It's a device that has got 4 electrodes, 2 above and 2 below the tongue. It's got a rechargeable control unit with a USB port, and it works in conjunction with your smartphone. The maximum current that you will deliver is 15 millivolts, and you can see this is the patient's device. This is the stimulator, and you can see the iPhone here, and you can see the patient with this in situ, and they only use this for 20 minutes. And here you will see various videos with different power setting. And if you look carefully, you will see the fasciculation of the tongue muscles where the stimulation is being done at level 3, level 6, level 12, and level 15. This is millivolts. And patients will start with lower intensity and then increase the intensity in order to tone the muscles of the tongue so that it doesn't go back and become retractile during sleep. So this was a paper we published in March 2021 in Sleep and Breathing. It was a prospective cohort studies with 70 patients. We asked the patient to use this for 20 minutes every day for 6 weeks. They all had a watch-packed sleep study 2 nights previously and 2 nights after the 6 weeks were over. Of the 70 patients, 38 had mild OSA and 32 were primary snorers, and we looked at objective and subjective parameters. This is the intensity, as you can see, from week 1 to week 6, they can go up to 9, 9.5. And the results were very encouraging. In the mild OSA patients, their AHI reduced from 9.7 to 4.8, and the ODI also reduced. The Epworth Sleepiness Score also reduced. This is just a pictorial depiction of the AHI, the ODI, and the ESS. And we did a multicentral trial with my friend and colleague Peter Baptista in Spain, and we looked at 115 patients, where we had quite a few patients, 65 patients at mild OSA. And again, this was statistically significant in reducing the dimensions, but this is only for mild OSA. We have got some work that is being done on severe OSA patients, whereby we're trying to stimulate the tongue so that it reduces the CPAP pressure. So patients will not come off the CPAP, but will be able to use the CPAP better because the pressure will be less. Finally, in the last 2 minutes, I just want to talk about hypoglossal nerve stimulation. This was first described by Kazilian in 2010, although the animal studies were done before then. And the best paper for it is the one in the New England Journal of Medicine by Strollo et al., who's looked at the STAR Inspire trial. This is a unilateral application. So you can see that there's a pacemaker in the chest, there's a wire that goes between the intercostal muscles, and there's an implant that goes onto the hypoglossal nerve here. So you have 3 incisions. You have one in the neck, one below the clavicle, and one between the ribs. And you put your stimulation leads here, your IPG is here, and your sensor lead is here. So the trial, the STAR trial, was published in the New England Journal of Medicine. It had 126 patients, and now we got data for 5 years. This is the one that used the Inspire model. Obviously, you have your exclusion criteria, and grade 3, grade 4 tonsils or retropalatal or circumferential collapse, according to the sleep endoscopy, has to be excluded because it won't work for those patients. So again, the key is patient selection. The median AHI dropped from 29.3 down to 9. And they also tried this with the patient's stimulator being turned off. So they could tell that when the patient's stimulator is turned off, the AHI is quite high. When it's turned on, it's down to low. They've got a 5-year outcome. Tucker Woodson has published data on this. And again, the response was very positive in 75%. So they have to adhere US upper airway stimulation registry trial, where they've got 1,017 patients, and they've done a 12-month follow-up with the median AHI dropping from 32.8 to 9.5, and the Epworth score similarly dropping from 11 to 7. Now, this is the new thing, Nyxoah bilateral stimulation. The first one I showed was the Inspire unilateral. This is the Genio system by Nyxoah, which stimulates the hypoglossal nerve on both sides simultaneously. This is battery-free. The Inspire has a battery which has to be changed after 10 years, but this is battery-free. There are no leads. The Inspire has a lead. There's an activation chip and a disposable patch. The incision is only one small single incision in the suprahyoid region, just above the hyoid bone, about 4 centimeters. And you have 2 sets of stimulators, these are activated by an activation chip, and it's all Bluetooth. The activation chip memory is stored according to the patient parameter, and the activation chip is rechargeable. So it's all pre-programmed before the patient starts, and this is what the stimulators look like. So this is for the right side of the patient of the hypoglossal nerve, this is for the left side, and this device is fitted into the neck like so. You can see the hypoglossal nerve here, you can see the stimulator on the left side, and the similar stimulator will be on the right side. This is the activation chip. So the studies that have been done, and Australia has been key in this. Eastwood published this paper in 2020, looking at bilateral stimulation. This was a prospective non-randomized study. It's a shorter follow-up, it's only 6 months, but the AHI dropped down by more than 50% from 23.7 to 12.9. Similarly, the Epworth Sleepiness Score and the Quality of Life Questionnaire were better, and the adverse effects were very minimal. So I said I wasn't going to talk about maxillar mandibular advancement. This is just one slide I'm going to show you. This is the skeletal framework surgery. Refer your patients to the maxillofacial surgeons if you've got severe retrognathia or severe maxillary retrusion. It is aggressive surgery, but this meta-analysis by Zaghi et al. In 2016 and the paper by Yu is very supportive. The British Medical Journal reported on the studies on bariatric surgery, and again, the Royal College of Surgeons of England are advocating bariatric surgery for syndrome X, or the metabolic syndrome, because it improves the patient's control of diabetes, hypertension, cholesterolemia, and obstructive sleep apnea. It is important to know that if you're going to perform surgery on these patients, the anesthetic input is crucial. Avoid pre-medication like temazepam, because that will suppress your respiratory centers. Avoid analgesia like morphine, because that will do the same again. Make sure you've got a nasopharyngeal airway. Make sure you've got a progressive care unit or a high dependency unit. So to conclude, ladies and gentlemen, there is a definitive role for upper airway surgery, and the evaluation of upper airway is very important. And as I mentioned earlier on, that you should do this with the patient awake and also with the patient during drug-induced sleep endoscopy. Patient selection is crucial. Look at general factors. BMI more than 32, 33, 34 will give you poor results. Consider combined treatment modality. Consider multi-level surgery. Consider surgery with other things like a mandibular advancement device, which might reduce the CPAP pressure. But the key take-home message that this should be a multidisciplinary problem which is addressed by a multidisciplinary approach. Thank you very much for your attention. Over to you, Arjun.
Hi. Hi. Brilliant presentation as usual. Bhik, a fantastic presentation. More or less kind of sums up everything that needs to be done when the CPAP fails. I will start with a little bit of controversy. Let me ask you, what is to do with the negative press about laser-assisted palatoplasty in sleep apnea? Can you tell us a little bit more about it?
So when the laser palatoplasty first came about, it was introduced by a chap called Eve Kamami, and he was doing palatoplasty on all patients, irrespective of where the problem was. So the downside is that, your patient selection for the correct anatomical problem. Obviously, you need to have laser safety in place, so that's important. And I have seen some patients where they do not use the backstop, or they do not put swabs in the postnasal space. And what happens there is, if you hit the posterior pharyngeal wall, you'll get nasopharyngeal stenosis, you get scar tissue forming, and that becomes very, very difficult. And that also hampers the CPAP use. So aggressiveness is what the laser is all about, but carefully used, it is actually very good and very useful.
Excellent. Second thing is the tongue-based surgery. You have a huge experience in the tongue-based surgery with robots. Do you use a laser in this robotic system, and what laser you're using?
So the one that I showed, we used thulium laser. It's a thulium laser because it comes in a fiber. You can get CO2 lasers that also come in fibers, but many people who do not have the laser, they use the spatula, like a cutting diathermy.
Yeah.
One thing that I haven't spoken about today, Arjun, is radio frequency.
Yeah.
Radio frequency, I have huge experience on radio frequency, but that's minimally invasive. And for patients who fail CPAP, they need a bit more aggression in the hypopharynx. And that's why radio frequency alone might not be good, unless if it's used in conjunction with other modalities. So radio frequency is a talk on its own, and I'd be very happy to do that in the future if you need me to do that. But radio frequency is an important development in this field. And I deliberately didn't say it because of the time purposes, the time constraints were such I couldn't talk about radio frequency. But that's an important one for a future date. So if you don't have laser, you can use the cutting diathermy. Coblation is something that you can also use. I know some of my friends and colleagues in India are using coblation, and that could give you similar results.
We have a coblation. We are using coblation. It's getting quite popular in India somehow or other. What is your thought about using a monopolar diathermy in a tongue test?
I think monopolar diathermy, unless you haven't got anything else, it's quite dangerous because you want to avoid the lateral 1.5 centimeter on either side of the tongue because your neurovascular bundles are going there. With monopolar diathermy, the heat energy can dissipate and you don't know how far lateral it's going to go. So personally, I think it's quite aggressive. I think it's not controlled. I think the rate of secondary hemorrhages are higher, rate of infections are higher. So you need to be more focused. I know that some of my colleagues in Italy, when they first started doing this, they were using a Doppler to see where the lingual artery is and try and avoid that. I don't use it. I just avoid the 1.5 centimeters on each side and usually get away with it.
Okay. So you personally do not use a Doppler, intraoperative Doppler to delineate the neurovascular bundles?
That's right. Yeah, that's the main reason for doing that. But I felt quite confident that if I wasn't going to the lateral 1.5 centimeters, I won't get it.
What are the experiences about the sleep nasoendoscopy? When you do a sleep nasoendoscopy, I remember that from my time, we are using the midazolam and propofol, and I find them very. What about the new drugs that has come in, the dexmedetomidine and?
So, with the drugs, people have looked at different aspects of it. They looked at the cardiotoxicity, they looked at the respiratory toxicity, and it's basically what works best with you. And since you left us, we've done a lot more work on the depth of sedation using bispectral index monitoring. You need a good anesthetist with you, and you might remember Paul Bailey, who was with us for 7 years, and he's worked with me for 30 years. So we've fine-tuned this. To be quite honest, I mean, when we first started, we were just using midazolam on its own, and we found that there was a very strong muscle relaxant. So we just use a very small dose of midazolam, just 2-3 milligrams of midazolam, and then titrate with target-controlled infusion of propofol. That really stabilizes your sleep quite smoothly, and I think that's better than the dexmedetomidine, because I think with the dexmedetomidine, the sleep induction is not smooth, and you can get peaks and troughs in the blood levels, and so that disturbs the sleep. Having said that, some of my colleagues in America think that's quite good, but there's not enough data for us to look at that and compare it with the propofol. But so far, the most popular drug is propofol.
Okay. The question I want to ask is about the nerves, the stimulators, the one you work with, the Exon, I think that's called.
Excite OSA, yes.
Yeah. How is it? I mean, does the patient sleep with the device in the mouth, or does he use it before the sleep?
They use it before they go to sleep. So it's like, when you go to the gym and you exercise, you strengthen your muscles.
Okay.
Similarly, electrical stimulation is muscular stimulation to the tongue before you go to sleep. So the muscle of the tongue are toned. And if you do that regularly for 6 weeks, the tone of the muscle tone of the tongue will be such that it won't retract posteriorly.
So they are commercially available in NHS and FDA.
I don't know about India, but I mean, I can put you in touch with them if you're interested. I did the research with the company, so I can email you and email one of the person here. It is very, very useful in selected patients. So again, mild OSA and simple snorers, slim patients who do not have large tonsils will do really well with it. I'll send you a copy of my paper, and then I'll send you the introduction with the guide. Fantastic. And then I think it'll be worth your while looking at that in India, because it's a huge market. It's got the FDA approval as well.
Okay. In India, we don't have any of the hypoglossal nerve stimulator or any of the nerve stimulators.
This is very cheap. I think in the United Kingdom, they're paying something like £600 or £640. And
so if you buy it in bulk, that's affordable. That's
affordable. And that's also not as invasive as having to cut the neck.
Yeah.
But it's not for severe sleep apnea, it's for mild sleep apnea and upper airway resistance syndrome.
What about your experience, or what do you think about the implantable hypoglossal nerve stimulators?
So I think that the one that I spoke about last, the Nyxoah one, the bilateral one, is very good. However, if you look at your whole practice, it's not going to be applicable to more than 5% of your patients. Okay. It's only applicable to between 2 and 5% of your patients. So it is absolutely not common, but you need to sort all the other problems out before. And it's only for CPAP failures. Okay. If the patient likes CPAP, get on with it, then great.
That's always.
It's the long-term compliance. And like I said, 35% failure rate in CPAP is quite a high CPAP failure rate.
Quite a high. Let me ask you a dumb question. And what I thought about it is that when you implant this device, the hypoglossal nerve stimulator, if the patient needs a pacemaker, where do they put that?
Opposite side.
Opposite side.
Opposite, yeah, because the pacemaker is always on your left and this is always on your right.
Okay, all right. It's always on your right.
Yeah.
All right.
Because it's a unilateral one, it's unilateral. So they always choose the right side because of that same issue. The pacemaker has to go on the left.
Fantastic. I mean, you gave a very good overview. I will just ask you a question because I don't get to interact with you like this for a long time. What is your thought? Because you have been there, you're an international leader in sleep technology and surgeries and treatment. So you have seen the whole sleep medicine start and develop slowly, and you have seen that. What do you think that from 10 years or 5 years, how is going to be? Because the problem is not going to go away. It's going to get worse, in fact.
I think there's a lot of developments. So I think artificial intelligence is going to be very good in selecting the upper airway obstruction, the segmentation. There's been a lot of work on phenotypes and genotypes of the palate as well. A lot of work on genetics of OSA. So there's a lot of advances. One of the trials that we tried in the UK on 2 occasions is to use tablets of some form to dilate the upper airway. So you just take a pill at night and it'll dilate the upper airway. But that has to be specific for the upper airway, whereas this was dilating everything else. So,
I understand.
So I think, we still, I think 10 years probably is not too long, because I started in 1995 as a consultant. And, at that time we were doing sleep endoscopy at Royal National, as you know, and now we've done about 30,000. And we've advanced the technique by using bispectral index monitoring and all the other things. There wasn't any laser when I started. There wasn't robotic surgery when I started. There wasn't radio frequency when I started. There wasn't hypoglossal nerve stimulation. So a lot of things are coming on. And I'm quite optimistic that in the next decade, you guys are going to be in the forefront with all the new techniques. So it should be interesting to see and watch the space.
Oh, thank you very much. It's a brilliant as usual talking to you. It was fantastic. And the people, there is a lot of people, to all the doctors over there who are not from ENT and the ENT. Not everybody tolerates CPAP. And there is a host of other options that Bhik talked about. Thank you. Thank you.
My pleasure. My pleasure. And if anybody needs any more responses, you can always ask them to email me. My email was on the front slide.
Over to you, Vaishali.
Yeah, thank you, sir. So I really thank Dr. Arjun Das Gupta, sir, for moderating session so well and putting forward such an important really clinically important questions. And I'm sure this discussion was very helpful to our audience. And I also thank Dr. Bhik Kotecha, sir, for such a wonderful presentation, for giving such a detailed overview of all the methods for treating the patient with obstructive sleep apnea when the CPAP fails, including drugs, various devices, as well as surgical techniques and his own Kotecha's technique, and also telling our audience the importance of multidisciplinary approach. It was a brilliant discussion and a brilliant presentation. Thank you so much for this wonderful session. And I thank our audience for spending their valuable time with us. Thank you so much, sir. And thank you all.
Thank you.
Thank you. And thank you for inviting me. It's a pleasure and privilege.
Thank you. It was fantastic tonight. Thank you.
Okay, bye.
Thank you.